Joshua. I'm going to do a quick talk on history taking for PLAB 2. So I'll discuss history, examination, and management, and then I'll finish off with a scenario and how I would approach it myself. This is the approach I used when I did my PLAB 2 a few years ago. I begin with this quote that emphasizes the importance of history taking, not just for PLAB 2, but in daily medical practice. It says it is now estimated that between 70 to 90% of medical diagnosis can be determined by history alone. In addition to being one of the oldest diagnostic tools, a comprehensive history is one of the most reliable. So I'm not a fan of acronyms, but I found this useful when I was doing my PLAB 2, and that's why I'm bombarding you with quite a number of them today. So the most important one we're going to look at is the first one, P3 Maftosa. The rest of the acronyms uh, fit in somewhere in this first acronym. The second one that I've put in bold is also an important one. It's ICE, which is important because it is worth about a third of the marks you get in every station in PLAB 2, your interpersonal skills. So P3 Maftosa stands for there are three P's and then, so the first three P is presenting complaint, the second P is past medical history, the third P is personal history of the patient. Then Maftosa M is for medication history, plus or minus mood, the patient's mood that is. A is for allergies, F for family history, T for travel history, O for occupation, S for sexual history, and A for anything else. I stands for um, ideas, concerns, and expectations. Very important in interpersonal uh, skills. The rest of the acronyms, the other three, I will discuss them as we move along. So how do you approach the station? So the first thing is P1, the first P. You approach it with an open question, trying to find out the presenting complaint by asking the patient, how can I help you today? Or what would you like us to do for you today? Then we analyze that presenting complaint. Tell me more about P1. And the patient will tell you what more do you need, or probably they'll offer more. But after they've asked you that, you need to analyze that by using the odd para or Socrates in cases of pain. So what does odd para mean? Odd para is what you will use to analyze every other complaint that is not pain, every other presenting complaint apart from pain. So you want to know the onset. The patient may have told you already, but by onset I mean did it come on suddenly or gradually? D is for duration. For how long has this been going on, or when did it start? P is for progress. Is it remaining the same? Is it getting better? Or is it getting worse? A is for aggravating factors. Is there something that brings it on, or that makes it worse? R is for relieving factors. Is there something that makes it better? Then the last A is for anything else that you'd like to tell me about P1, your presenting complaint. So remember, when you tell the patient, tell me more about P1, they may have answered some of these questions. So it's upon you just to fill in the gaps on what they have not asked by going through the odd para acronym. Or Socrates in case of pain, what does Socrates? So if a patient presents with pain, headache, tummy ache, or pain for whichever part of the body, then you will use the Socrates acronym. So S is for sight. Can you point to me where you feel this pain? So they could point at a specific point, or say it's all over my abdomen or at the back, whichever. O, onset. It will come on gradually or suddenly. C is character. How does this pain, what's the character of this pain? Is it a sharp pain? Is it a dull pain? Is it a crampy pain? Is it comes and goes? R, radiation. Does it this pain go anywhere else? Does it radiate to some other part of the body? A is for associated symptoms. Does this pain, is there anything else with this pain? And then T is for timing. When does this pain come on? Or for how long has this pain been? Since when? E is for exacerbating and relieving factors. Anything that makes it worse and what makes it better. Then F is for severity. Tell the patient to score the pain on a score. If you one is the least and 10 is the worst pain you've ever felt, what number would you give your pain? How much score will you give it? After you finish analyzing the presenting complaint, ask the patient, do you have any idea what will the reason be behind the pain? Why? Because patients normally have some idea about what's going on in their bodies. They may not be medically trained and they probably don't know exactly what's wrong, but they are looking, sometimes they're actually looking at the right places. I mean, they're probably Googling and the right things. So you could ask them any idea and they'll tell you, I've just looked at the internet and I think it could be this. And it is also at this point that sometimes they give you a hint that will help you know exactly what you're dealing with. So if you don't test the ideas early enough, you may waste a lot of time trying to rule out so many differentials when you could have just asked the idea first, and it will have helped you to narrow down your list of differentials and save you a lot of time in chasing ghosts, if I may call it that. Then tell them you've mentioned you have P1. Is there anything else? You've mentioned you have this presenting complaint. Is there anything else with that presenting complaint? After you've done that, we've uh, we've asked about associated symptoms. I believe you would have asked this. So you try to rule out differentials. So for example, if somebody comes in with chest pain, your main differentials will be a respiratory cause or a cardiac cause. So try to ask if they have any breathing difficulties or if they've coughed out blood or they have any swelling on their limbs. You're thinking about pulmonary embolism. If you're thinking of cardiac causes, you could ask about palpitations, syncope. And in differentials, you don't need to ask a long list of differentials. Just ask, for the exam purposes, maybe two or three would be enough. Just rule out some differentials. And then also ask about, when your differentials, you should also maybe rule out sinister things like cancer, so weight loss and night sweat, I mean sweating, fevers, or lymph nodes, any bumps and lumps anywhere in the body. So you've ruled out your differentials. So the second P is past medical history, and I like to break this down into two parts. So the P2A and P2B. P2A is a past medical history of this particular presenting complaint. Say they are coming in with chest pain. Ask them, have you ever had chest pain before? Have you ever had this kind of pain before? Or have you ever had this kind of dizziness before? Or have you ever had whatever they came in with before? Then the second part of past medical history is now the historical bit. Do they have any other medical conditions like high blood pressure, like high sugars? And they'll tell you yes or no. Have they ever had any surgery before? Have they ever been admitted to hospital before? Then P3, the third P is personal history. And for this is where that acronym DESA comes in. Diet, what's the diet like? Exercise, smoking, alcohol, stress, recreational drugs. Again, you don't need to ask all of this. Just look at the scenario and pick out what's important for your scenario. I'd probably say smoking and alcohol and recreational drugs are important for almost all scenarios in real practice. You should always perhaps ask about that. Diet and exercise. Well, it depends. If it's somebody coming in with a fever lasting 2 days or one day, diet and exercise probably not very useful things to ask. But if it's you're thinking about an eating disorder, then diet and exercise become very, in fact, they become the primary things you'll be focusing on, and you'll probably even ask them earlier than this. So you finish your P3, go to the maftosa, ask about medication, plus or minus their mood, ask about allergies, family history. These ones are important in almost all scenarios. Again, medication, allergy, and family history. The rest, of, of course, and the last A, anything else that's important. But the T, O, and S, it depends on the scenario. Travel history, occupation history, sexual history. You don't need to ask in every scenario. Just ask in scenarios where they're relevant. And then summarize to the patient. So just tell the patient, I'd like to summarize everything you've told me. You've mentioned you have A, B, and C, and probably, and you also hypertensive if they say that. Did I get that right? And the patient will say yes. Is there anything else I missed? And they say no or yes. If you've missed something, then ask about the expectations at this point. Is there anything you expect from us today? Why do you ask about the expectations here? Because the next thing you want to do is to examine them and probably send them for investigations. So you want to know if they were expecting a particular kind of examination, if they were expecting a particular kind of investigation, and before you start doing that, and if they're expecting it, you also want to manage the expectations. For example, if somebody comes in with dizziness and they're expecting an MRI, you want to tell them in the most polite way possible that uh, you want to manage that expectation. So basically, the way you'll do it, I'll say, is that's a very valid thing. For example, if you ask, is there anything you're expecting for us today? And they say, well, I was thinking I probably should get an MRI because of this business that has been disturbing me. And you tell them, well, that's a very valid thought. So acknowledge it's a valid thought because it actually is valid. Sometimes you may need MRIs for people who have dizziness. But you, you tell them, but I want first to examine you and assess you fully, and then we'll make the decision as to whether or not we need to do an MRI for you. So you have acknowledged that the expectation is valid. You've not dismissed it, even though you're probably not going to do it if somebody is coming for business for 2 days uh, and there's nothing unusual that is pointing towards a brain lesion. You just say, yeah, acknowledge it's a valid thought and tell them, I'm going to assess you and then we'll make the decision later. You may actually find that in assessing them, you would find some lateralizing signs and you actually need that MRI. So, in as much as you probably, from the history, you didn't think they needed the MRI, the examination could actually tell you, actually, we need a brain scan, CT scan, MRI. So, just acknowledge the thought and tell them, after I've finished everything, we shall make the decision later. Uh, so we go to the next point, but before we go to the next point, so we've already finished the P3 and the maftosa. Let me just mention some specific contexts where the history varies a bit, some things that you need. So in pediatrics, there's another acronym. I'm sorry about the many acronyms, but I found them useful, so I think you probably find them useful. So pediatrics, you need to ask about the birth history. Was it cesarean or normal? Antenatal concerns, if there are any. Postnatally, was the child resuscitated? Was they admitted in hospital? And then uh, anything else about the birth you want to know, if it's cesarean, the reason for the cesarean. Then go to the immunization. Just ask if they're up to date. Red book. Red book is a book with a red cover that children in the UK are given, or parents actually, not children, but yeah, it belongs to the child. It's for the child's health record. So all the immunizations, their growth chart, everything, the health visitor will be recorded in this book. So ask about the red book. If possible, just say if there's any concerns that have been recorded in the red book or anything. And for PLAB 2 cases, just also ask about development. You may not need, because this is not a pediatric exam, you don't need to specifically ask the milestones that you just need to ask a broad question like, do you have any concerns about the growth and development of your child? And that's enough for PLAB 2. If it's a pediatric station, you probably need more detail than that. Then OBS gynae, you need to ask these three periods. How are their periods? Regular, irregular? When was the last time they had them? Pills, basically pills includes all manner of contraceptives. And they on any contraception, and what kind of contraception? Is it an implant? Is it an IUD? Or is it actually a pill? So we're just calling it pills for ease of memory, but it includes also non-pill contraceptives. Then pregnancy. Have they ever been pregnant before? And what was the outcome of those pregnancies? Maybe they've lost a few, or they've terminated a few, or they're all fit, alive, and well. Or they've never been pregnant, but ask about it. In psychiatry, there's FAMISH. F stands for four F's, basically family, friends, finances, forensics. Have they ever had any run-ins with the police or law enforcement authorities? A is for alcohol and drugs and smoking. M, medical history. I is for insight and interest in life. S is for sleep, stress, and appetite. H is for hallucination or thought disorders. So anything that points towards psychosis, thought insertion, thought broadcasting, and all those psychiatric things. So that is just a special mention for those special contexts. But let's not forget the first bit was P3 maftosa. And then you've summarized and you've asked the patient about the expectations, and then now you move on to examination and initial tests. Again, at this point, I just take a break and read one of my, not mine, but one of those quotes that I put in here. When you're a doctor, you know that every day you'll touch a life or a life will touch yours. So it's an examination point that you quite literally have to touch the patient. And so for at examination, you will mention at history taking, you'll not really be determined if it's an history taking station, not be expected to examine the patient, but you're expected to mention that you will examine the patient. And what do you mention? Mention that you like to check their observations. So this includes the blood pressure, heart rate, respiratory rate, and oxygen saturation. Then also mention that you like to examine them from head to toe, and depending on the specific symptom they came with, also mention the particular system. So if they head to toe, and specifically I'll also look at your abdomen if they came in with abdominal pain. And then tell the patient that we may also send some initial tests, which include a full blood count, urine electrolytes, ECG, a chest x-ray, and explain them after you've mentioned them probably in layman's language. So we like to check the levels of the cells in your blood, the salts and water in your blood. That's where the salts in your blood and electrolytes, and the trace of your heart if you're talking about the ECG, or the function of your liver and the kidney, depending on whatever test you're going to order. So that's the examination bit. And then you go to management. So in management, you want to take the concern that's ICE, the C part of the concern. Remember, we did the ideas when we were doing the presenting complaint. We did the expectations when we finished the P3 maftosa, and now we're doing the C, the concerns and acknowledgement. At this point, the assumption is as a doctor, you've already known the diagnosis or known the most likely diagnosis. And so you're telling the patient, because you've already examined the patient, you've taken history and you've done initial tests. So you now want to break the news to the patient, what their diagnosis is and what you're going to do. That's management. So you want to, first thing is to know their concerns and acknowledge it. So tell them, may I know what worries you the most? And then acknowledge that's a very valid concern. And this is, I'm now going to tell you where we think, what we think could be the main reason and how you're going to address your concern. So tell the most likely diagnosis is X, Y, and Z, or X. You probably don't have Y and Z. And then explain. what that diagnosis means. Actually, check if they know. For example, if you say it, I think your symptoms is because you have a stroke. Now ask them, do you know what a stroke is? Or have you ever heard of that before? Probably have heard, they probably haven't. If they say no, explain it to them. If they say yes, also still continue to explain it to them and tell them it's because of this particular thing happening to your brain, the blood vessels doing X, Y, and Z. And then you, after you've explained, tell them I'll provide you with a leaflet that has all this information. I know it's a lot that I'm telling you right now, but I'll give you a leaflet with all this information, and it also tells you what to do and what to look out for. Remember, always remember the setting you are in. If you're in a GP setting, which is a primary care setting, you don't have specialists around, you don't have all investigations around, so you cannot tell somebody. The question says you're in a GP setting, you don't say you're going to do an MRI in a GP setting or you're going to talk to the cardiologist. It's not possible in a GP setting. You can only refer them for that. But if it's in a hospital, you could say that because in a hospital probably you have these people around. Then once you've explained the diagnosis and explained it to the patient and offered them a leaflet, if you said you're going to offer them the leaflet, also tell them I'm going to discuss with my seniors. Remember, PLAB 2 is set at the level of a foundation year doctor, so everything you do must always be in consultation with your seniors. So tell them I'll also discuss with my seniors and inform them of everything you've told me and all everything I found out from examining you. And we may want to do further tests. You can tell them what tests you want to do further after discussing with your seniors and why. If it's something that can be treated symptomatically, you also tell them we'll offer you this to manage your symptoms. I tell them about the red flags. If X and X happens, for example, if you're thinking it could be an infection, ask, tell them if you develop fevers or you lose consciousness, whatever it is, red flags. If you're thinking cancers or strokes or those things, call the ambulance or come back to us immediately. If there's reason for specialist test, mention it. If not, don't mention. If the scenario could be managed by lifestyle changes, also mention it. If not, don't mention it. If there's need for follow-up, tell the patient that you follow them up. Well, so let's take an example of a scenario and then I will tell you how I would have approached it and then we finish it off. So this is the scenario. Mrs. Smith, 71-year-old lady who has been complaining of dizziness. Please take a history and give your diagnosis to the examiner. So I'm standing outside the exam station and this is what has been written on the door. This is what will happen on exam day. So you have such a scenario. So what do you do? In that 1 minute or 1.5 minutes that you're standing outside there are two things you need to be doing. You need to be planning how you will approach this. So you know already it's a history taking station from what the question is saying. So quickly just put in your head a structure. It's P3 maftosa, you know that. And then after that, I'll need to do an examination. And then after that, and in examination, what I need to do is vital signs, head to toe exam, and probably mention the initial test. And then management. So in management, I need to check patient concerns, explain the diagnosis in layman's language, offer leaflets, say that I've discussed with my seniors, and mention if you need any further tests or symptomatic treatment or all those things. So you've already put that structure in your head. And then the second thing you need to do quickly is also think of the possible differentials. You cannot do all this in 1 minute if you've been doing it. So what are the possible differential in a 71-year-old female with dizziness? At 71, they are already getting into old age, so they probably have a bunch of medications. So medication is a possibility that's a cause, a side effect of one of her medicine. It could be stroke at 71. She could be diabetic, so hypoglycemia is a possibility, or diabetes itself. It could be anemia. I mean, they maybe have some chronic disease, anemia of chronic disease, or it could be electrolyte issues again, secondary to the medications they are taking. So you've already thought of five. It's a good list. Of course, you also think it may be trauma. Maybe they've had a fall and then trust issue or infection, whatever it is. So keep an open list of differentials at the back of your head. You don't need to think of so many, but just keep an open list. The main thing that you should have in your mind, and I emphasize this, is your approach. Why? Because if you have that approach, the differentials will fall into place. That's what I believe. So the first minute, that 1 minute outside the door, it's your time to think of your approach. If you have more enough time, you can think of your differentials. So what? How will I approach this? So I have a 71-year-old lady. I've opened the door, entered the room, and I now start with an open question. I'll first of all introduce yourself. Say I'm Joshua, one of the junior doctors in the department. So very nice to meet you. May I please confirm your name, and they'll tell you your name and what how and your age, please, and they'll tell you whatever they are. I'm Mrs. Smith. I'm 71 years old. Great, nice to meet you. And then you start. So how can I help you today? That's an open question, and they'll tell you, Doctor, I've been having this business that's disturbing me. And tell me more, please. And they'll offer to tell you more, or they'll probably ask you, what do you want to know, doctor? And then you tell, now you start analyzing it. If it was pain, we'll use Socrates, but because this is business, we use odd para, so we ask, did it start on gradually or suddenly? And then they'll answer you, when did it start? We're trying to get the duration, progress. Has it gotten worse? Has it gotten better, or has it remained the same since it started? A, aggravating factors. Is there anything that brings it on? And they'll tell you, oops, whenever I'm lying flat and I try to rise up, or when I'm seated and try to stand, it just brings it on. Any relieving factors? I feel relieved when I sit still or when I lie still. Anything else? That's the A for odd para, and they'll tell you if there's anything else. And then you ask them, any idea what could be the reason behind your P1? I mean, supposing they said, I'm not sure, but I think it's the new medication that the GP started me for. I mean, that's a very important hint. So you see why you need to ask the idea very soon, very early. I'm not saying that always happens, but if it happened that way, you will be saying, thank goodness I asked this thing very early, and that they've already given me a hint that it's possibly a medication issue. So you want to know what medication is this, and lo and behold, if it's your lucky day, you find out it's a thiazide diuretic, and you're saying, oops, you've already clinched the diagnosis in your first 2 minutes of the consultation simply because you asked the idea soon. But that's a very good day. It may not be that way, but ask it. Then mention, sorry, you ask the patient, you've mentioned you have dizziness. Is there anything else you have with the dizziness? And they'll tell you no, yes. Then continue asking if there's any associated symptom. Whether or not they say no, yes. If they say yes, well and good. They say no, now it's upon you to try to help the patient to see if there's any associated symptoms. So what would normally be associated with dizziness? Usually you could find perhaps nausea and vomiting or blackouts. They probably have lost consciousness at some point or syncope. So ask if those things are there. Then remember your short list of differentials. In the exam situation, you don't need a long list. In real life, you probably will need, you also don't need very long lists, but you need a longer list. So ask about two or three. So ask, have you ever been told you have low blood levels before if you're thinking of anemia? Do you have weakness in any part of your body, legs or feet, or changes in speech if you're thinking of stroke? Uh, do you have any fevers at all if you're thinking of meningitis or some infection that's causing that? Any discharge from your ear? And they'll answer you. So ask some questions about the differential diagnosis. Then P2, the past medical history. So start with the past of this presenting complaint. Has this ever happened before? Yes or no? Then 2B, do you have any other medical conditions? They say yes or no. They'll tell you they're hypertensive. I'm just running around with the idea that probably it is your good day and the patient is hypertensive and they had a change to a thyroid diuretic and so they have hypotension, postural hypertension. So they tell you, yes, I'm hypertensive. Just ask them what they use for their hypertension if possible. Surgical history, hospital admissions. Then DESA, again, this one you'll just ask according to the scenario. So in this scenario, diet may be important because you want to rule out anemia. Exercise, probably not. Smoking, very important. I mean, if you're thinking stroke and that kind of thing, and also analyze the smoking, how much they smoke. Stress, maybe, maybe not. Alcohol, very important. It could be the cause of the dizziness itself, or it could lead to other things that will cause the dizziness. And recreational drugs, also very important. So DESA, just ask those things that you think are important depending on your scenario. If it's not important, leave it out. Then maftosa, medicine, very important. What do they have any medicines they use regularly? And what are those drugs? Sometimes you may find that a patient, remember in maftosa, just going back a bit, when you ask about the past medical history in P3, the patient may not have mentioned they have some conditions. They probably will not mention diabetes. But then in Aspen, the medicines they use, they tell you they're using metformin, and then it's you who the doctor will ask them, why are you using metformin? And then they tell you, oops, I actually have diabetes. So always ask any medication, ask allergies. I always ask about the family history. The T, O, and S, you may or may not want to ask them depending on the scenario. Travel history, occupation, sexual history. For example, in this scenario, I don't think the sexual history adds any value. Then A, anything else, always ask that in P3 afterwards. So the ones without the plus or minus, those are things you should ask in almost every scenario in Maftosa. And then the ones of plus or minus, it's upon you to make a judgment depending on the scenario. So in our scenario, I mean, you could get away without asking the travel history, the occupation, the sexual history. You could get away with it. Medicine, I don't think you will get away with it. Allergies, it's important, perhaps not to give you the cost, but when you're trying to manage the patient later on, you want to know the drugs you're giving them. Probably they might have been allergic to it before. And then summarize. Mrs. Smith, you have mentioned you have dizziness and probably something else, and that your GP changed your medication recently. Am I right? So you actually tell the patient, I just like to summarize everything you've told me. You've mentioned that you have X, Y, and Z. Am I right? And the patient say yes. Is there anything else that I've missed out on? Always add that when you're summarizing. And the patient helps you to, it kind of helps you to get everything out of the patient. If you've missed out something that the role player knows you should have asked, they could probably help you if you ask, is there anything else that you think I've missed out? And then before you move on to the next step, which is the the examination step, ask expectations. What do you expect from us today? So the patient will tell you if they're expecting any kind of investigation or any kind of examinations, or if they don't have expectations, they will just say they just want to get better, which is also an expectation anyway. Then we move to examination and initial tests. So you say, Mrs. Smith, I'd like to examine you, and that will involve me checking your pulse, blood pressure, your temperature, your respiratory rate, and the level of oxygen in your blood. I'll also examine you from head to toe. And because you mentioned uh, that you have dizziness, I may also want to check your reflexes in different parts of your legs and arms. Is that, and then once you've mentioned that, the patient will say yes or no. Yeah, okay. They'll not say yes or no. Sorry, they will allow you to move on to examine them. You may also want to mention that we'll need to do some initial tests just to check if everything is okay. So this test will include a full blood count, U&Es, the function of your kidneys, the liver, and a trace of your heart. For the full blood count, you'll check the level of your blood cells. The U&As will also be checking the level of your kidney functions and all those things. So mention the test and try to explain it in layman's language to the patient. And once you've mentioned this, it's at this point usually that the examiner will show you a card to see if maybe if the patient has some deranged observations or if they have some deranged blood tests, you will be shown by the examiner. Or sometimes they may just tell you everything is normal, proceed. If they don't have that card in the room, sometimes they'll just. So if you don't mention, what I'm trying to say is that if you don't mention that you're going to check the observations, the examiner will not show you the examination, the observations, if at all they are supposed to be showing it to you. Once you've done that, now you go to management and say, concern, Mr. X may know, Mrs. Smith may know what you're concerned the most about, and then tell them the diagnosis. I think you're having what is called postural hypertension. Mention the diagnosis in medical terms because that was part of the question. And then ask Mrs. Smith, do you know what that is? And Mrs. Smith will say, no. And then you tell them, explain it to them now in layman's language. And tell them the reason they're having this is because probably they were started on this particular medication by their GP. You're going to give them leaflets that explain everything about this condition and what they need to do and what they need to be aware of. Then move on to the next step and say you're going to discuss with your seniors. And depending on the situation now, the rest will be basically dependent on the situation. If there's need for further tests, tell them you may need to do further tests. If not, you don't need to mention symptomatic treatment. You can tell them for now, I'll just advise you to be taking a lot of water. Make sure you're well hydrated. And then red flags, tell them if, for example, you develop any weakness on one side of your body or difficulty with your speech or vision or loss of consciousness or convulsions or any other thing that you think you're worried about, let us know immediately or come back immediately or call the ambulance. And you can mention if there's need for special tests. Lifestyle for dizziness, you'll probably tell them, I'd also advise you to avoid driving at the moment when you're still having this dizziness and operating some machines. And then follow up if there's need to arrange follow up. And finally, for that interpersonal skills, these are the things they look at: how you go to the patient and introduce yourself, how you listen to the patient, if you're listening, if you're explaining things to them in layman language, if you're empathetic, eye contact, your body language, your facial expression. Every time you explain to the patient whether or not you're checking the patient understanding, if you're giving the patient confidence and you yourself look confident, and of course, how you close up the consultation, that is by thanking the patient and the examiner. Best of luck. Thank you for listening to me, and I wish you the best.